Dustin, one of the sleep fellows, is going to talk about COVID-19 and sleep. Kind of revisit the pandemic, the lockdown, the effects on sleep and the general population, those affected with the virus itself. Talk about long COVID as well, its relationship to sleep and sleep disorders, and then touch on emerging evidence from our Pediatric Long Haul Clinic, which is in the works of being published, and want to give a shout out to Dr. Sally Ibrahim and Shika Mystery for allowing me to present some of their data that's in the works, and then also discuss a case of sleep disturbance and the setting of COVID, again, out of the Pediatric Clinic under Dr. Sally Ibrahim as well. So going back, during 2020, 2021, there's a lot of growing concerns about sleep. The number of articles in the media as well as the scientific realm really exploded. And JCSM did look at this and looked at Google Trends in the first 5 months of 2020 and found an uptick of 60% queries for insomnia compared to those same months over the previous 3 years. So it was certainly on a lot of people's minds within the general population, as well as in the world of sleep. So disturbed sleep in the public. About 40 to 60% of the global population, and again, this is those not, this is the general population, so those that weren't contracting the virus, about 40 to 60% felt like they had disturbed or reported disturbed sleep. And this was data in 2021. And why this was, there's certainly a number of reasons, but there was a toll on mental health during this time. An increase, so those that weren't experiencing mental health difficulties, there may have been new onset changes, or those with experienced mental health disorders and exacerbation of those symptoms. And during this time, there's association with negative symptoms, depression, anxiety, psychosis, rumination, as well as somatic symptoms. And really, there was a massive change in life during this time, as we can all recall in the not so distant past. But illness, fear of illness, employment, financial security concerns, food security concerns, the ability to buy food for family, changes in education, kids going to remote learning, which I know a lot of teachers, that was a great amount of difficulty communicating with students during that time. The general effects of the lockdown, which I'll touch on, in evening, increase in use of electronic devices, so some changes in sleep hygiene as well. So this was seen across all age groups, pediatric population, adolescents, teens, kids that are in college, even to the adult and geriatric population as well. There were changes with nightmares. A study out of Italy on the next slide I'll touch on. How the mandatory lockdown affected everyone's day-to-day life. Change in exercise, the ability to exercise, gyms were closed. Some folks were afraid to go outside, so less likely to get outside, experience green spaces, which even just being around green spaces and outside has been shown to decrease cortisol, decrease stress levels as well. Less outside time, less physical exercise. There's benefits on sleep and with those relationships as well. And a change in sleep schedule. A lot of us kind of depend on work as a motivation to stick to a sleep schedule without work. Some folks are getting out of bed, ability to sleep in a little bit longer, changes in social jet lag as well. And it was found just being at high risk for COVID infection, or living with someone who's at risk, or having a friend who may be infected with COVID were risk factors in themselves for poor sleep quality. So this was that graphic on nightmares, a study out of Italy published in 2021, which looked at dreams, self-reported dreams with positive emotions versus those dreams with negative emotions, or nightmares, looking at gender, female versus male, age, younger population less than 40, sleep disturbance index, anything over 5 was considered to correlate with sleep disturbance. The PSQIA was related to symptoms of PTSD, and the state trait anxiety inventory 1 and 2 scores 40 or above were consistent with anxiety, and then the Beck depression inventory 13 and above increased, or less than 13 increased risk of depression. So female gender, the decreased age groups, more likely to report nightmares. Those with sleep disturbances more likely to report nightmares. In those experiencing PTSD symptoms, anxiety or depression, more likely to report nightmares affecting sleep quality. And this is one thing that I remember watching the news, at home with my parents, and, certainly there was a respectful amount of fear with the virus and the lockdown within the general population and medical community. But I just remember seeing a naval ship liner coming in, and all the reports within New York. So it's not a surprise that maybe those that were anxious to begin with and watching this in the media, maybe these images are popping in at sleep, or worrying about loved ones, someone that they know, living in a hot spot for contracting the virus. So that was the general population. What about healthcare workers? A lot of us were on the front lines, but there was a massive psychological impact, including PTSD symptoms, as well as isolation, whether that's, isolating from their family at home, not going to family gatherings, just knowing that they're at high risk of exposure, that social isolation took its toll, again, from a mental health perspective. And it was shown that there was an increased risk of COVID infection in shift work, as well as those with irregular sleeping patterns, and who experiences that more than a lot of healthcare workers. But the risk was, one study, about 1.2-fold greater for 40 minutes of increased variability in sleep timing. And along that same line, sleep deprivation, is being sleep deprived associated with worse COVID outcomes, possibly, but sleep deprivation is associated with increases in the same pro-inflammatory cytokines, namely IL-6, TNF-alpha, associated with severe COVID infection, the cytokine storm that often ensues. Some of the sleep deprivation came from experimental animal models, where those animals that were sleep deprived showed increases in viral susceptibility, increased resistance to anti-inflammatory effects of steroids. So that's important kind of in the inpatient ICU setting. Those that meet septic criteria, septic challenges, and just show increased mortality in that setting. Additionally, sleep deprived animals related to respiratory pathology with COVID. There was induced pulmonary inflammation. So that may be playing a role in the COVID pathogenesis. But what about the case for better sleep during this time? So this is not quite related, but the old Inspire commercial. I just always, every time I see this, I chuckle, and I think we've all seen this going from the dog showing on your CPAP to improve sleep. But the case for better sleep during this time, there was more flexibility within the schedule. So some that was adversely affecting, but for some this proved to provide better sleep. Certain populations were more apt to have the ability to sleep along their circadian preferences, maybe getting more sleep, experiencing less social jet lag, kind of sleeping in during the week, and roll out of bed, pop on the computer for their Zoom meetings. So for some, there was more of an improvement in sleep schedule. And those with sleep disorders, specifically hypersomnolence disorders, actually saw some improved symptoms I'll touch on later, but the ability, more flexibility to nap during the day, maybe sleep a little bit longer as well. Some accommodations that aren't at work, they have the ability to do at home. So now switching to population of those contracting COVID, specifically related to insomnia, sleep disordered breathing, hypersomnia, as well as restless legs. But a couple studies, pretty wide pool prevalence estimate, those infected with COVID-19, pool prevalence from 35 up to 75%. So new onset insomnia was found, it's a pretty high prevalence, over 50% of patients based on insomnia severity index scores 4 months after hospital discharge were consistent with insomnia. Another cohort of confirmed COVID patients, and this was both outpatient and inpatient, reported insomnia. Cited reasons for that were anxiety, nocturnal respiratory symptoms, cough, congestion, dyspnea, increased pain or changes in pain, as well as fever. The severity of infection also seemed to play a role. So insomnia was found to be more common in patients who were severely affected at 6 months after the discharge, compared to patients who have had other respiratory infections. About a third of patients with severe infections were found to have neurological or psychiatric disorders within 6 months after hospital discharge. And the quote severity of infection wasn't quite clearly defined, but generally those required hospitalization, needing supplemental oxygen. Certainly those that found their way to the intensive care unit may or may not have required mechanical ventilation, oftentimes for prolonged periods as well. Everything that goes into hospitalization, especially intensive care unit, changes, potentially in sleep-wake cycle, being woken up throughout the night with alarms, testing, and so forth, made it more difficult when they recovered after the hospitalization. Regarding sleep disordered breathing, there's certainly a case for new onset sleep disordered breathing in those not diagnosed with sleep apnea, contracting the virus, experiencing everything that came with the pandemic, and then later being diagnosed with sleep apnea. One reason may be more interaction with the healthcare system, where there is a certain population of sleep apnea that's not diagnosed and more likely to interact with the healthcare system and have that discussion come up. During this time, there was weight gain noted, again, less physical activity outdoors, fitness centers being closed, changes in lifestyle habits, increased alcohol consumption during this time as well. Potentially an upper airway pathology. There was an EMT journal had reported changes in voice and hoarseness, which may suggest a viral effect of the upper airway. Changes in cardiac pathology, new onset heart failure, a quarter of those hospitalized patients, as well as about 1/3 admitted to critical care units. This could be direct viral cardiac injury, changes with acute respiratory distress syndrome, changes with pulmonary hypertension, pulmonary pressures causing new onset heart failure, or like a stress cardiomyopathy, inflammatory cytokines as well, impairing cardiac function, viral infiltration causing atrial fibrillation as well. So a lot of reasons for changes in sleep disordered breathing related to a cardiac pathology. Potentially viral injury directly to the brainstem could reveal a centrally caused mediated contribution to respiratory dysfunction as well. There's a lot of shared risk factors in those that are more likely to contract the virus, overlapping with those at higher risk of sleep apnea, notably obstructive sleep apnea, metabolic changes, obesity, hypertension as well. And it was found that those patients with obstructive sleep apnea had an 8-fold greater risk of COVID infection compared to controls receiving care. And this was a population that was racially and socioeconomically diverse, but one healthcare system. So sleep apnea, obstructive sleep apnea patients with COVID do appear to have a greater morbidity and mortality. But why is that? We discussed the shared risk factors may be more likely to have to contract the virus. So the SARS-CoV-2 virus binds the ACE2 receptor. It was found that there's increase in expression of ACE and dysregulation of the RAS system in obstructive sleep apnea. So that may promote viral infection. OSA itself certainly can exacerbate hypoxemia, worsening COVID pneumonia, and we know that OSA is a pro-inflammatory state, as well as obesity. So this may augment the cytokine storm, which is associated with some of the worst outcomes with COVID. Again, the severity of infection playing a role here as well, specifically acute respiratory distress syndrome. It was found that 49 of 67 COVID-19 patients who actually survived ARDS later underwent sleep testing were found to have moderate to severe sleep apnea, specifically obstructive sleep apnea 4 to 6 weeks after discharge. And another study showed that OSA diagnosed after discharge was associated with a 6-fold greater odds of having ARDS while infected with SARS-CoV-2. So switching to hypersomnia and central disorders of hypersomnolence, there's no consensus link between the two, nor no direct proven pathophysiology. One cohort did report 17% of those infected had hypersomnia. However, they did not define what how they diagnosed hypersomnia. There was no mention of an Epworth scale there was no PSG, MSLT testing. So it was more of survey data they didn't report, so kind of take that with a grain of salt. But this may be related to direct foreign mediated action of the virus. There were some studies, autopsy studies, showing routes of CNS entry, viral particles and RNA of the virus were found along the olfactory mucosa, as well as the CNS areas that receive projections from the olfactory tract. Certainly, viral particles can cross the blood-brain barrier, and it was also found that viral RNA was identified, or where it was identified within the central nervous system. There was also evidence of CNS or inflammatory response and damage mediated by microglia in that same area. So any damage to either the hypothalamus, hippocampus, brainstem can be affecting sleep, hypersomnia, as well as sleep disordered breathing, as we mentioned earlier. There were a handful of case reports as well of post-COVID hypersomnia, specifically narcolepsy. So one of them was a 33-year-old female that was previously healthy following recovery from COVID, started experiencing symptoms. She had, mild to moderate COVID, was treated symptomatically and supportively in the outpatient setting. No antivirals were started, did not require hospitalization. But she was reporting sleeping at least 8.5 hours a night, then developed pretty severe visual and auditory hallucinations, described sleep paralysis, as well as experiencing cataplexy, specifically with laughter. So she presented, I believe, 9 months after COVID diagnosis to a neurology clinic. With this presentation at PSG MSLT testing with an MSL of 1.5 minutes and 3 out of 4 naps experienced sleep onset REM periods. And another study out of the American Thoracic Society described a similar picture. 45-year-old female, relatively healthy, history of hypertension as well as migraines. Presented sleeping up to 16 hours a day. Again, did not require hospitalization when she was diagnosed with COVID, was treated symptomatically and supportively in the outpatient setting. And her Epworth was 24, and she underwent sleep testing with MSL 2 minutes and 2 out of 2 SOREM periods as well. So certainly, a viral etiology and potential mechanism. Yeah.
So I'm very interested in ICU delirium and neuro patients who have a baseline neurological insult because of the blood flow changes and inflammation states that exist. So I've been following sleep and COVID very closely because there are a lot of overlaps with how delirium looks and how these long states of COVID look. But the way that you described the first patient, to me, that looks like mixed delirium, like a mixed state delirium, a combination of hyper and hypoactive delirium behavior. And then that other state, also sounds a little bit like delirium to me, more hypoactive delirium.
Talking about narcolepsy. You need to see a narcolepsy patient. You need to talk to a narcolepsy patient. Right, that's their diagnosis, and they do that. They have brain fog.
Yeah.
They have all sorts of stuff. They have this,
It's so interesting how much overlap there is between these two. So,
but it's very uncommon. We have one here, but they probably had it before they had their COVID, but
Okay.
didn't know that they had it.
Okay,
But the idea of, I mean, why sleep medicine is interested in this is because we know how to talk to people about fatigue
yeah.
and brain fog and neurology and rheumatology don't.
Correct. That's, I mean, from my experience, because we don't do, I mean, working in neuro, I see, we don't ever do any sleep apnea testing when we know they have sleep apnea based on how they were when we were weaning them off the ventilator.
So the most common diagnosis in neurology now for long COVID. Britain is functional neurological disorder, FND.
Yeah, I'm familiar,
It means that they can't find it.
right. But but that comes with the burden of like, oh, this is all psychological, because that's kind of like, in the past, at least, when they came,
Yeah.
That's yeah, exactly.
People with narcolepsy come to us after those diagnoses.
Okay, is neuroinflammation a factor in these people with narcolepsy months after COVID, or do you know?
So, what you're talking about are the limits of neuroimaging to be able to identify various things. Closest thing is myalgic encephalitis chronic fatigue syndrome, MECFS, and the images is right at you can be able to do those. And this particular institution is not a center for developing things to do that sort of thing. You saw there was just a recent one on Havana syndrome. Said there is no neurologic disorder detected by MRI. I don't think they were looking at connectivity.
Yeah.
Connectivity is the important part. All right.
Online, is my screen still sharing online? Try to look for comments. I guess however it's not sharing. Yeah, I think a lot of that is interesting in the ICU though, related to, we usually see delirium with the hypomania.
Yeah,
Is also often overlooked.
Yeah.
It's everything else.
exactly.
A lot of overlap with sleep and delirium and just all that can. I guess on a positive note related to central tourism and somnolence, the pandemic did allow for more flexibility in day-to-day life. I thought it was really interesting that up to about 50% of patients with type 1 narcolepsy reported a decrease in cataplexy during this time. And much of that was related to the ability to attain more sleep, experience less sleepiness, ability to have naps throughout the day as well. And then rounding this up, just restless legs. Not overly common. I didn't find a lot of great, prevalence data. More so, a couple case reports, and typically both mild COVID treated in the outpatient setting as well as those hospitalized. But pretty significant temporal relationship developing RLS with a week or two of being diagnosed with the virus. And it's not known exactly why this happens, but may be related to systemic inflammation, increasing hepcidin and the changes with bioavailability of iron. So a relative iron deficiency causing restless legs. Most cases were typically self-limited to 2-3 months or so. And came across this as well is some sleep testing after COVID recovery. This was a small study, a small group of patients did show REM without atonia up to 36%. So COVID-19 may be affecting neurological pathways that preserve atonia and stage R sleep as well. And of this population, there was a lack of current or more complex behaviors during sleep. No use of medications that would affect this stage R sleep either. So now moving to long COVID and disturbed sleep. Just want to revisit long COVID itself. And this was a meta-analysis of a review of symptoms out of nature. Certainly almost 60% fatigue, headache, some attention difficulties, changes in mood, anxiety, depression, dyspnea, almost a quarter, as well as cough, chest pain. And these persistence of symptoms, maybe weeks, months, and even some, we're seeing today can be years. So the estimates of those with COVID who go on to experience long COVID have varied. I saw estimates up to 30%, 20%, even lower, closer to 10%. The prevalence, the most recent data from the CDC of 2023 was stated at 6% of adults, which fell from 2022, decreased by 1.5%. So what's causing long COVID? It's poorly understood, but there are different hypotheses and even different phenotypes, where the hypotheses include different pockets or pockets of the virus hiding out, causing persistent chronic inflammation, chronic exposure to the immune system, and really interfering with the normal function of the immune system. The phenotypes often are mixed. I think more, we're seeing a lot of the brain fog and chronic fatigue overlap, as well as some respiratory chronic dyspnea, amongst others, some post-exertional malaise as well. And biomarkers of inflammation, fibrosis, as well as alveolar repair may be some of the biological drivers of the respiratory symptoms. So this is one of two more recent studies with long COVID that I thought were interesting. Came out kind of at the end of this year, and then one was published publicly in January. But there's persistent complement changes with active long COVID, where the complement cascade is in essence always turned on, causing changes in platelet activation, thrombal inflammation, clotting, further tissue damage. And tissue damage in itself is a trigger for the complement cascade. So that was pretty interesting. That I believe this was the first time that the complement system was directly described with serum testing. And additionally, in nature, muscle abnormalities were found to be worse than long COVID. So this study looked at and compared a population of those with long COVID to a population that had contracted COVID but made a full recovery. And before and after exercise, they looked at some blood testing as well as muscle biopsies as well. And they found that there were severe mitochondrial dysfunction in the long COVID cohort, where the mitochondria had difficulty utilizing oxygen and creating energy. On the muscle biopsies, the long COVID arm also showed more muscle damage, atrophy, as well as evidence of clotting within the muscle. And it was interesting that some of that clotting was within the muscle and not within the vessels. So that begs the question, if microclots are found in the muscle, are those, in other organs, are those in the brain? Possible etiology of some of the brain fog and other pathophysiology or symptoms that we're seeing with long COVID. So long COVID and disturbed sleep, pretty significant prevalence of 34 to up to half of the patients having disturbed sleep in long COVID. Another online survey with, I believe, a little over 300,000 respondents in 56 countries over the course of 7 months, showing nearly 80% of respondents admitting to disturbed sleep, with insomnia being about 60%, night sweats 41%, trouble breathing at night 36%, restless legs 18%, and sleep apnea at 10%. Some of these factors, include changes in sleep disorder breathing, changes in neurologic or psychiatric sequelae that we've talked about. And this was, I believe, published midway through last year out of the Recover Initiative, looking at those with premorbid sleep apnea and the risk of long COVID. They used 3 large databases. 2 were adults, totaling a little over 300,000 adults. 1 was pediatric, about 100,000 pediatric. More of chart review, machine learning analysis using diagnostic codes at follow-up. But they found no significant increase of long COVID in premorbid OSA in the pediatric population. But the other 2 populations showed an increase of 12% in one, up to 75% in the other, which is a pretty massive difference in association. So reasons for that: the 2 populations looked at different definitions of long COVID. One was a little bit wider casting net, and the other was a more strict definition of long COVID. So the strict definition of long COVID, there were fewer adults found as having long COVID, but there was a higher percentage of that population were sleep apnea patients, thus showing an increased risk up to 75%. So, in reality, it probably lies somewhere in there, but certainly an increased risk of long COVID and having sleep apnea. Why is this? Again, there's a lot of overlapping risk factors with COVID. Contracting the virus itself, having received outcomes, and underlying sleep apnea, the metabolic changes, chronic inflammation, obesity, what have you. Intermittent hypoxia, increased sleep fragmentation, and augmented inflammation caused by sleep apnea may cause some of the sleep-related symptoms seen in long COVID. And again, sleep apnea may have more severe COVID symptoms. Thus, more severe infections may more frequently lead to experiencing long COVID. And sleep apnea dampens, decreases the body's immune system, so increased inflammation, and again, a greater propensity to develop infection. So I think there's plenty of questions that remain, and remain some limitations to the study. As far as the population, the degree of home testing may have been missed. Those patients that did have the virus were included. But they didn't mention the severity of OSA, you know, is this mild, moderate, severe? Is there a role or change in variant? You know, is the Delta variant more likely to play a role into long COVID versus Omicron, et cetera? The vaccination status wasn't taken a look into. Was this sleep apnea treated versus untreated? Wasn't mentioned, which I think, you know, would be a great next step. You know, you could argue that someone that has great compliance, very well treated sleep apnea for 5 years. At that point, do they really have sleep apnea? So that would be interesting to separate those treated versus untreated. And then is there a specific long COVID symptom? Yeah, that's more closely associated. I think it's a respiratory, cardiovascular, and neurologic, cognitive, brain fog changes, brain changes with digestion. This study looked at short sleepers as well as short sleepers with pre-existing medical conditions. We wanted to see if their sleep duration influences any relationship with pre-existing medical conditions as well as long COVID. Sleep duration was defined as short sleep was less than 6 hours, normal sleep was 6 to 9 hours, and long sleep was anything over 9 hours. And pre-existing medical conditions, they looked at, you know, chronic cardiac disease, hypertension, heart failure, AFib, chronic respiratory disease, COPD, asthma, chronic neurological disease from changes in cognition to movement disorders, autoimmune disease, patients with cancer, patients on immunosuppressants, those with chronic pain, as well as chronic psychiatric conditions, anxiety, depression, etc. So what they found, comparing, you know, sleep duration, specifically those with pre-existing medical conditions to those without. So those with so those short sleepers with pre-existing medical conditions had a 3 times risk in long COVID than short sleepers without pre-existing medical conditions. So it's comparing these two groups. But when you compare short sleepers, again, less than 6 hours with pre-existing medical conditions to normal sleepers without pre-existing medical conditions, there was a 1.8 risk, 1.8 times higher risk in probability of long COVID. So this represents, you know, a potential modifiable behavior to reduce the risk of long COVID, specifically those with pre-existing medical conditions.
You know, if those are SEM bars or standard deviation bars?
I believe standard deviation. I'm not sure. No, it's specifically sure.
Still open.
Yeah. And I believe this is the last study I wanted to talk about. This was a survey study published in Journal of Internal Medicine at the end of last year out of the Cleveland Clinic, and was first to really look at sleep disturbance severity. So how everything talked about sleep disturbance, this looked more at severity. and if this was related to long COVID. Using the PROMIS sleep disturbance scale, they found that 41% with long COVID experienced at least moderate to severe sleep disturbance. And further, Black race being hospitalized for COVID, having an increased anxiety severity, moderate or severe fatigue, looking at fatigue scales, were associated with moderate to severe sleep disturbance. And to round things out, wanted to discuss in the works of being published from our pediatric long COVID clinic. Again, thanking Dr. Sally Ibrahim and Shika Mystery, who are in the works of submitting this for publication. But sleep disorders in children and adolescents with long COVID. So a retrospective cross-sectional study of patients presenting to the pediatric long haul COVID clinic here through Rainbow Children's, and looking at the prevalence of sleep disturbance, comparing those with and without sleep disturbance in comorbidity as well as symptomatology. So methods, single factor regression analysis used to explore this relationship, and multi-factor regression analysis with the PROMIS sleep disturbance score as the main predictor, with several response variables, including child well-being, general fatigue, sleep rest fatigue, cognitive fatigue, total fatigue, anxiety, and depression. So 250 patients were included, with age ranging from 3 up to 24 years. 63% were female, 80% white, and 82% non-Hispanic. So of the 250 patients, 64 or 26% had sleep disturbance. And that included circadian rhythm disorders at 28%, insomnia 31%, hypersomnia at just over 1%. In comparing the non-sleep disturbance group to the sleep disturbance group, those with sleep disturbance were more likely to report additional comorbidities, including abdominal pain, nausea, constipation, anxiety, depression, ADHD, headaches, dizziness, POTS, brain fog, fatigue, appetite loss, as well as fever. So kind of hard to see on these sidebars. But this is a PROMIS sleep disturbance T-score and regression analysis. So A, B, C, A being child well-being score, B, the sleep rest fatigue, and C, total fatigue, where higher sleep disturbance scores negatively associated with well-being, sleep rest fatigue, and total fatigue. And then there was not a significant relationship found with the general cognitive fatigue scores. And I believe these kind of the R value was, I believe this was about -7 for child well-being. The sleep rest fatigue was about -5.5, sorry. So -0.7, -0.5, and -0.6. And there was a linear relationship between sleep disturbance and anxiety score here. So more sleep disturbance was associated with higher anxiety scores. And then B, more sleep disturbance was associated with higher depression scores as well. Sleep disorders are prevalent among youth with long COVID, and they often coexist with high rates, physical, neurological, as well as psychological symptoms that were discussed a couple slides back. And higher sleep disturbance scores within the pediatric long COVID patients predict lower well-being, as well as higher mood, specifically anxiety and depression scores. There's certainly other impactful factors, but it's suggested that sleep is playing an integral role. And these findings are suggesting that sleep disturbance is a key factor in overall health, as well as mood in the pediatric population with long COVID. And lastly, I wanted to take this time kind of fit in here to discuss a clinical case that I wrote up for the sleep conference under the supervision of Dr. Ibrahim as well. Kind of a unique clinical scenario. But at the time, 13-year-old female who had a mild COVID infection. This was about a year prior to her initial sleep visit. She was seen in the long haul COVID clinic. When she came to us, she had ongoing sleep onset and maintenance insomnia, significant circadian delays, significant sleep inertia, as well as daytime brain fog and headaches. She did have some intervention prior to seeing us, working on the sleep-wake cycle. They made some progress with sleep timing, but there was still significant sleep fragmentation, unrefreshing sleep, and hypersomnolence persisted with an Epworth of 15 when she saw us. And this was despite a sleep duration typically over 12 hours within a 24-hour period, including pretty significant nap time. This was affecting her daytime function at school, often needing to be pulled out of school for sleepiness as well as headaches. So we did go ahead and pursue sleep testing, which PSG looked relatively unremarkable, no sleep disruptors, 8 hours of sleep, and there was some delayed slow wave sleep periods, which may be seen in an idiopathic hypersomnia type picture. Her sleep testing, it wasn't off the charts impressive. Her MSL was 15.4 minutes. Her first nap may have had the kind of first nap effect with her MSL of 4. Maybe suggestive of sleep deprivation, often getting 12 hours in a 24-hour period, needing naps. She had 8 hours that night before. She had no REM, no SOREMs. Or excuse me, she had 1 SOREM. So differential, we were working with hypersomnia due to a medical condition versus idiopathic hypersomnia. She, with MSL of 15.4 minutes, didn't meet strict criteria. She had a trial of daytime stimulants, which was up-titrated, specifically Concerta, which showed mild improvement. When we saw her back, her Epworth, when we first saw her was 15, it was 14. So after a lot of discussion, a trial of sodium oxybate was pursued, and then in follow-up after that, this resolved her sleep inertia. She was waking up more refreshed. Sleep quality had improved. Less nighttime awakenings. Her Epworth improved, initially 15 to 14 with stimulants, down to 4. She was able to return to school full time and reached normal functioning. And she said back in office, she felt like she was back to her normal self. So this case highlights, that there's no established guidelines, in treating hypersomnia, related to, long COVID. There was one case of long COVID and ADHD, like, syndrome that responded to daytime stimulants. So with this, and coverage of the medication was done through the Jazz Pharmaceuticals, as well, since that strict definition wasn't met for idiopathic hypersomnia. So it's take-home points, relationship between sleep and COVID, it's often bidirectional, multifactorial. The pandemic itself had detrimental effects on sleep to the general population and those contracting the virus as well. The virus and severity of the infection is associated with increased sleep disturbance, with insomnia, sleep disorder, breathing, restless leg, as well as hyposomnia, pre-existing sleep apnea, and short sleep may be associated with increases in long COVID. That's all I have today.